The numbers on your blood test looks like objective science. Two numbers based on data stamped onto your result. But the story behind those numbers is far more complicated than it appears. And in some cases, those numbers have not been updated for years. They are built from a population that may not represent you. They are designed to identify disease, not define health. Today, we are going to pull back the curtain on how these ranges actually work. Welcome to Opti Labs, where we decode your lab results and reveal the deeper story behind the numbers. I am Dr. Austin Odigie. Reference ranges use something called the 95th percentile reference interval. Here is what that means in plain English. A lab takes a large group of people, ideally healthy volunteers, measures a specific marker in all of them, and then takes the middle 95% of results as the normal range. The bottom 2.5% and the top 2.5% are outside normal. This means that by design, 1 in 20 people who are completely healthy will have at least one test fall outside the reference range on any given draw. If you run a panel of 20 tests, the probability that at least one comes back outside the range by random chance alone is roughly 64%. This is not a failure of medicine. It is statistics, but it has real consequences. Patients get alarmed by results that are statistically insignificant. Doctors order follow-up tests that lead to more follow-up tests, and resources, time, money, and anxiety are spent on findings that means nothing. The second problem is who the reference population is. In an ideal world, reference ranges will be built from a rigorously screened, optimally healthy people from diverse demographic groups. But in practice, that is extremely difficult and expensive. Many reference ranges were established decades ago using whoever showed up to a clinic and agreed to participate. Those people were not necessarily healthy. They were not screened for early disease, nutritional deficiencies, or lifestyle factors. They were a convenient sample. The result is that some reference ranges have absorbed the chronic diseases of modern life into their definition of normal. If half the adult population is insulin resistant, and you use that population to set a fasting glucose range, your range will reflect a pre-diseased state. This is exactly what happened with fasting glucose. The upper limit is 99. But research on long-term cardiovascular and metabolic risk has consistently found that risk begins to increase in the 85 to 90 range. The range wasn't updated because the range isn't designed to optimize. It is designed to divide the sick from the not yet sick. Here is what surprises a lot of people. The same blood drawn on the same day can produce slightly different results at different labs. And the reference ranges attached to those results can also differ, sometimes substantially. Different labs use different equipment, different reagents, different calibration standards, and different reference population. A TSH range at one lab might be 0.4 to 4.5. At another lab, it might be 0.5 to 5.0. Vitamin D optimal cutoffs differ between labs. Even the units can differ. This matters because if you are tracking your results over time and you switch labs, you may be comparing results that aren't directly comparable. Always note which lab ran your test and try to use the same lab for longitudinal monitoring when possible. Reference ranges are often not adequately stratified for age and sex, and almost never for individual factors like fitness level, body composition, or genetics. Creatine is a good example. Creatine is a waste product filtered by kidneys, and it's also produced by muscle. A highly muscular person will have higher creatine simply because they have more muscle mass. Their result may come back elevated and trigger concern about kidney function when their kidneys are actually working fine. Conversely, a very elderly or frail person with very little muscle mass may have low creatine that makes their eGFR looks better than it actually is. Their kidneys might be poorly functioning, but the low muscle mass is masking it. Alkaline phosphatase, or ALP, is another example. During adolescence and pregnancy, ALP rises substantially due to bone growth and placenta production. An elevated ALP in a teenager is entirely normal. In an adult with no bone disease or pregnancy, the same level warrants investigation. So what does this mean for you? This does not mean you should ignore your labs or distrust the system. Instead, it means you should approach your lab results with appropriate nuance, rather than treating reference range as a bright light between healthy and not healthy. When your doctor says a result is normal, it means that it's within the statistical range of a large mixed population. That's useful information, but it's not the same as saying your level is optimal for you or that it's healthy given your specific history and goals. Ask where you fall within the range. Ask whether your result has changed since last year. Ask whether there are more sensitive tests that give more context. That's not being difficult. That's being a participant in your own healthcare. In the next video, we are going to talk about common blood test mistakes, things that can throw off your results before you even walk into the lab. If you've ever wondered why your fasting glucose or total cholesterol look weird, this one's for you.